All right, let's see what happens next.
Well, you're feeling better, right? And Dr. Rescotra here will sign you out.
He has a low-grade fever. Maybe we should observe him for a bit.
Come on, it's barely a low-grade fever, please.
CBC shows a left shift.
Yeah, but there's no leukocytosis.
You want to write up his aftercare?
No, read the CBC.
I mean, you don't have to do that for me.
I'm not doing it for you. His history tells me to do it.
So interestingly, they're really focusing a lot on this CBC or complete blood count. What do you make? What do you make of this? How would you utilize it in your evaluation of someone with abdominal pain?
Well, the two things, I think people do use a CBC, and particularly they look at the white blood cell count a lot with abdominal pain, but the evidence just isn't there that we can really make that diagnosis. And the reason is that benign causes of abdominal pain, like the stomach flu, can give you quite a high white count, or white blood cell count, and surgical causes can frequently present with a normal white blood cell count. And so I don't think that it's a useful test in general in differentiating a surgical from a non-surgical cause in a patient. You know, you could potentially look at the platelets as an acute phase reactant, but that's going to have the same problem where it can be any infection can lead to an elevation.
So it's neither sensitive nor specific.
Nor specific, that's right.
Okay, so it really does, it's like flipping a coin. It really doesn't help. But what about in this case, they said, all right, maybe the first white blood cell count was normal, but I'm going to wait and get a second one, something called a serial CBC. Do you think that would be better?
No, I don't think that's of any utility either for the same reasons we mentioned previously. Serial CBCs aren't going to be any more sensitive or specific, I don't think, than just getting an individual one.
Absolutely. This guy comes in with abdominal pain. The CBC isn't the only test we can get. What else would you get in someone with abdominal pain?
Well, in abdominal pain, I think that, you know, it depends on whether it's a man or a woman. If it's a woman, you clearly want to get a pregnancy test. That's, you know, number one, even if they, you know, say they're not pregnant. But along the same lines with that is you're going to want to get a urinalysis in both a man and a woman, because we talked about kidney stone, or even a urinary tract infection can lead to that. And then other abdominal labs such as liver function tests, a lipase or amylase to look at the pancreas. We frequently get electrolytes in these patients as well, with a creatinine to check for kidney function, and a glucose, because diabetic ketoacidosis and other diabetes complications can actually present with abdominal pain. So
you really tailor the labs you get to what you're worried about in your differential diagnosis?
Absolutely.
Okay, great. And they've got a decision to make here with this patient. The doctor is ready to send him home, but it's not really clear. What do you think? What the options are? Send him home, observe him, get additional imaging. What would you do, or what could you do in this circumstance?
Well, I mean, I think that, you know, you don't want to just jump immediately to additional imaging in a patient like this. This patient is saying he's better, right? Your exam, although it was brief, was unremarkable. And there aren't a lot of really concerning signs right now in this patient, but there's a few. So this is a patient who's in that gray zone where I wouldn't send this patient home at this point because of that initial history of the severe pain and this kind of slightly elevated temperature and other things like that that just kind of make you think the patient may be sick and you don't really know why. But I'm clearly not going to jump to a lot of imaging that could be either expensive or, more concerning, could be dangerous to the patient, such as from radiation.
Sure. Sounds very reasonable. Let's see what happened. In this particular case, as Dr. Strelo said, the white blood cell count is of little clinical value in the patient with possible appendicitis, and again, it's neither sensitive nor specific. We often hear of doctors that are relying on the white blood cell count to make the diagnosis when it really, the history and the physical exam are going to be more valuable, and you want to put the entire picture together, everything that you have, history, exam, lab findings, their serial assessment. When you look at all those things, then you can decide whether the patient might have a particular diagnosis or not. And we keep mentioning that the patient has a low-grade fever, but the reality is it really doesn't distinguish between a medical versus a surgical cause. A medical cause like stomach flu, surgical cause like appendicitis.
Very similar to the white blood cell count in that regard. You're going to see it in both conditions.
Okay. We mentioned imaging. Some things that you have the option of doing are ultrasound. So in this particular case, ultrasound here shows the appendix here between these two stars. It's about 7 millimeters and non-compressible. Any advantages to ultrasound? Is there any set of patients that you would get it on?
Yeah, we always use ultrasound as our first choice in children, pregnant women, and actually in most younger patients I do. I know that we actually have a policy to use it in children and young women, but I actually use it in almost all my young patients for starters because they're at a higher risk from the radiation of a CT. So ultrasound's a nice option for that.
Absolutely. And those with a sort of a thinner body habitus also probably going to be more utility. The other imaging study that's frequently done is a CT scan. And what this CT shows right here is an enlarged appendix with a bunch of what we call appendicoliths. And if you look around the appendix also, you can see that there's fat stranding or inflammation of the fat. And what are those appendicoliths? Well, when you remove the appendix itself, you can see they're just basically little stool balls that get caught in there and start the process of inflammation.
Blood work's back on your no doubt unfairly prosecuted, wrongly incarcerated, rule out Appy.
Hey, I told you to discharge him, didn't
Well,
I?
his white counts up to 12,000.
Big deal.
What,
So
if his appendix burst on the way here, his pain might have been temporary. We should wait, see if he declares himself.
Forget it. I already examined him. You gotta go.
His temperature's up to 100.4.
Well, it could be an appy. Right.
No way. It's impossible.
Let me take a look.
Well, the initial exam could have been done in the post-perforation window.
Right, but then he have signs of peritonitis, wouldn't
Takes
he?
a while to develop.
Steve. Hey, Steve.
His diaphoretic belly has a pulse.
All right, 2 liters wide open. Put him in Trendelenburg.
Okay, can you get his cuffs off, please?
All right, all right.
Abdomen's rigid as a board.
Can't be. He was completely soft.
Pressure's only 70. Help. He's gonna need a second IV.
All right, give him a gram of Suboxetine.
We're gonna take him to the OR.
We get his pressure up. He's septic. Mix up dopamine. Run a VTAC.
Okay, get the crash cart!
Wow, this patient's condition really turned for the worse.
Quickly.
What do you think happened?
Well, I think that physician was probably correct in thinking that patient's appendix probably perforated or burst, as she said. You know, and if you have an appendicitis and it perforates, you now basically can get diffuse peritonitis and get septic quite quickly. This is a little faster than you might expect, and it's still, we want to do serial exams in these patients because I don't think they change often this fast, but that's probably what happened.
So there was kind of this window after the appendix burst where the pain went away, so that the abdomen quieted down, sort of this danger period, this lucid interval like we see with head injuries before the patient got really worse.
Right. And that's why we frequently say things like we want to admit and observe instead of admit and ignore, right? So this is a patient that if you were checking on them regularly, you would have seen this progression into where they ended up.
Why was the patient so sweaty and why did he have such a low blood pressure?
The patient was in shock.
Okay.
And so that patient, you know, obviously went into septic shock. And from that, they're going to be in a vasodilatory state, and their cardiac output's actually going to probably start to decrease due to that sepsis as well. And so they're going to have dilated blood vessels, and blood pressure is going to go down and going to go into multi-organ dysfunction if they're not careful.
So in this sick patient now, what's the next step? What should we do?
Well, I think those physicians handled it fairly well to start with. You know, you have to focus on your resuscitation at that point, and you're going to think, you know, just going in there and surgically taking it out immediately isn't going to fix the problem. At this point, the patient is in shock, so you need to treat the shock first. But part of that shock treatment, as they were talking about, is getting the patient to the operating room and doing source control. But for the shock, I would do aggressive IV fluids. Okay, so you know they ordered 2 liters in this patient, but that patient's probably going to need a lot more than 2 liters. They ordered some vasopressors, and vasopressors are appropriate if the rapid infusion of fluid isn't bringing up the blood pressure quickly. And then they got the antibiotics on board, which is something that we know that time to antibiotics is critical in sepsis now, and that getting those antibiotics on board can decrease the mortality rate.
So it sounds like after they discovered that this guy was septic, they started instituting everything appropriately.
Yeah, I think they did a nice job.
Okay, let's see what happens next.
OR3. He pumped your lap, Coley. Hey.
He looks upset. We've all had cases where things don't go the way that we hope for.
Yes, we have.
In this particular case, there's always something we can learn from or do better the next time. So what advice would you have in terms of looking at this case? What can we do better the next time?
Well, I mean, I think it was pretty obvious that this doctor went in there and had already made up his mind before he saw the patient. He was being dismissive of the patient long before he entered the room, and when he was in the room, you know, you could see he didn't ask a lot of questions because he already made the diagnosis. So he didn't really need to ask a lot of questions. And I think that premature closure, we sometimes call that, and that's going to cause you a lot of problems, actually. And I think it's a pretty common thing, especially in a patient like this who may be coming from, you know, this patient was like incarcerated or coming from a facility like that. And I think that it's easy for us sometimes to say, oh, that patient's always here, they always have this, or they always have that, and not keep an open mind.
Yeah, you get that tunnel vision, you've decided on a diagnosis, and you're locked into it, and unfortunately, as you could tell, the other doctor was trying to warn him. That other doctor was trying to tell him, hey, you know, the white count is up, there's a little bit of a fever, there could be perforation, but he just didn't want to listen. He already decided, and sometimes when we let our egos get in the way and we get too focused on our own diagnosis, we make mistakes for the patient.
Yeah, I think always checking, you know, how you feel before you walk into the room is actually really important. You know, if you're really tired, then you might need to take a minute out and just relax for a minute before you go in and see a patient. Or if you have strong feelings about a patient, actually, which you can have sometimes, if you have those, you need to take a minute out and kind of check yourself at the door before you walk in. Otherwise, you're going to fall victim to tunnel vision and premature closure.
Absolutely. Well, that's been great. This has been the Abdominal Pain Discussion, Case 1, with our expert, Dr. Matthew Strelo. Thank you.